So I'm going to jump into the presentation. So in the meantime, if you guys have any questions, feel free to ask in the comment sections. When I am done with the presentation, I'll be answering all your queries. So let me get started here. Okay, so today's webinar is about connecting OpenEMR with other systems using APIs. So I'm not sure if you guys were available for my previous webinars, but just to give you a quick introduction, I am Sid. I am the Senior Accounts Manager slash Business Manager at Capminds. I oversee health IT implementations and integrations. I have been in the health IT industry for about 8 to 9 years now. So I'll be going ahead, and today's topic is about system integrations with OpenEMR. So we'll talk a little bit about OpenEMR integrations and how other systems are being interconnected in today's world. So we'll look at some methodologies such as APIs, HL7 FHIR, and how we are using that to leverage OpenEMR's capability to connect with other systems. So this is going to be the agenda today. So we'll just have a quick welcome and introduction. Then we'll have, we'll learn more about what are OpenEMR APIs and why it matters. Then we'll jump into what are the different types of systems and how we're using that to integrate with OpenEMR. Then we'll look at some real world integration challenges and then how we solve them. And then we'll have a use case walkthrough towards the end. So, just to give you a brief recap of what OpenEMR is, OpenEMR essentially is a open source EMR platform. It is ONC certified, which is the governing body to ensure that all of the data that is flowing through OpenEMR is HIPAA compliant and it follows all the major guidelines. And then if you're talking about the usage of OpenEMR, it is used by almost 100,000 plus providers across 30 plus countries. Since it's OpenEMR, the reach is quite astounding. Then it has 30 plus languages. So it's not only available in English, but other languages as well, such as Spanish, French, and other major languages as well. Now, if you're talking about how many people are joining in, I think this number is a little bit old, but at least 4,000 to 5,000 people download OpenEMR through the official repository every month. And then there are about 174 plus active development companies who serve using OpenEMR. Let me just quickly change the view here. So now moving on to the next topic, which is what is OpenEMR API integration. So just to give you a simple example, let's say you have a EMR system and you want it to talk to your payment system. So we use something called APIs, which allows endpoints to talk your EMR to the payment systems. For example, if there is a payment coming in, you can just use the API connectivity to ensure that that payment is being tracked directly into your OpenEMR system. The problem it solves is that you don't have to do a lot of manual work. So taking the payment and then adding it manually, it can be done automatically and both the systems can talk to each other. Now there are different integration interfaces. There is FHIR-R4 RESTful API, which is the major API version, which is used across all the major systems. Then we have Classic REST API. So Classic REST API is before FHIR-R4 RESTful API. Then we have HL7 V2 messaging. Then we have CCDA documents. So we'll dive into more detail in what are these integration interfaces and where they're used. So moving forward. So another question that comes in is why OpenEMR API integration is an immediate priority, or just in general, why integration or interoperability is a major priority right now. So one reason is very simple. Since the healthcare ecosystem keeps growing, there are multiple devices, there are multiple systems you want your EMR to talk to and get the data. So rather than doing all the manual labor to put that in the EMR system, there is a need to have a API integration or interoperability standards. Now, some other reasons also listed down here is first, we have the 21st Century Cures Act. So it means that in this act, it is mandated that we have a open data access. Information blocking violations carries fines up to $1 million per instance, and compliance is something which is not optional. So with this act, you need to make sure that all the data that is flowing through your healthcare ecosystem needs to be recorded. And one good way of doing that is using the interoperabilities, which we are going to walk through now. Now, the second thing that comes in, which is the most major reason, in my opinion, is the patient expectations. So 99% of hospitals now offer patients the ability to view their records electronically. So the patients now expect a seamless, unified health data. Another important aspect of patient expectations is right now you might have seen an increase in HIEs, which are large databases that pool all the patient data, and with their consent, they can take the data to anywhere, any provider, and once the consent is given, that particular provider can view the data on their end as well. Now, the third reason, which is a little bit of a futuristic reason, or the present reason, which is related to AI. So, as we all know, that AI is now being integrated in almost all aspects of technologies and softwares. So, most EHR platforms will embed these AI capabilities, but it only works when it has a clean stream of data. So, otherwise, it will throw up errors, or it will not give you the accurate information that you are seeking. Now, moving forward. Now, looking at some system integrations of OpenEMR, where in what major areas the integrations are being developed and used on top of OpenEMR. This is not just for OpenEMR, but other custom EHR, EMR solutions, and other major EHR solutions as well. If you would have used an EHR, you would know that these are the main systems that they offer. So the first one is the lab information systems, or laboratory information systems, or LIS in short. So what happens is, just to give you a simple walkthrough example, is that you can generate lab orders right away from the OpenEMR system if it's integrated properly. And then that lab order goes to the respective lab. They receive it on their interface, and then they perform the lab procedure, and then they upload the results, or the machines are directly integrated to their LIS, and that particular result comes in through a unique ID to the OpenEMR system. So that integration is how it works. Then we have pharmacy and e-prescription. So this is one of the most major requirements that the healthcare providers have nowadays, is for e-prescription. So, as you know, OpenEMR is fully capable of working with major, e-prescription networks such as SureScripts, DoseSpot, Dr. First, and all of these. And, OpenEMR can work with any major e-prescription provider as well. Just to give you an example, it can work with New Crop, we know other major e-prescription vendors as well. Then the third system is the hospital and health system. So here we need bidirectional data exchange between different hospital information systems. So it can be Epic, Cerner, Meditech, and it enables care coordination across different systems as well. Then we have medical billing and RCM. So if you're using an external RCM system, usually hospitals and large clinics, they prefer that they have all of their financial data in another system. So if you're using something like that, you need integration to perform all of that data and secure flow of claims and everything as well. Then another one is telehealth platforms. So you can embed video visit platforms such as Zoom, Twilio, Doxy.me, Teladoc directly into OpenEMR so that you can do virtual care for your patients and the patients don't have to travel to the clinic for simple diagnoses. Then we have patient scheduling systems. So you can connect with online scheduling tools such as ZocDoc, Acuity, Calendly, so patients can book, reschedule, and receive reminders without staff intervention. Now moving forward. Some other systems which are listed down here also are patient engagement and patient portals. As I was, showcasing you earlier that patients require their health records nowadays. So if you have patient engagement systems or patient portals, you can integrate OpenEMR directly, and you can supply that data. Then we have insurance and payer systems here. So if you have direct API connections with insurance payers or clearinghouses, you can check real-time eligibility, you can do prior authorizations, you can see claim statuses and all of that as well. Now, the ninth system is AI and clinical decision support. So you can connect to AI-powered CDS, you can see diagnostic tools, and you can use predictive analytics engines to give you actionable insights on point of care. Now, then we have analytics and reporting dashboards. So if you have, third-party tool, or if you want to develop a custom tool that gives you analytics and reporting dashboards, you can connect using OpenEMR. You can supply the data, and they can run the charts for you. Patient portals is something we already spoke about. So we will go to the next system. Now, this is a priority matrix. So based on overall my experience so far, what do the providers prioritize and what do they need, in different tiers of integrations. So most of the providers, when they reach out to us, they request medical billing and RCM integration because that's where the financial cash flow of the healthcare clinic or hospital is. Then they request for insurance and payer systems to run eligibilities, prior auth, as we went through already. Then comes patient care, which is the patient portal. So a lot of providers request that we connect to a specific patient portal, or we build a custom patient portal fully integrated with the EMR system. Then we have labs. Then we have pharmacy and e-prescribing. Then we have patient scheduling. Then we have telehealth platforms. Then internal health systems. Then we have analytics and reporting. And then right now we have seen an increase in AI and CDS as well. So this is an overview of what providers are prioritizing with relation to integrations. Now, looking at what are some of the integration challenges that we face. So, the number one pain point that stops integrations or interoperability is obviously data security and HIPAA compliance. Obviously, connecting two different systems and building that bridge is not a big task, but to make sure that that data security, it follows all the security protocols and it follows all the HIPAA compliance related compliance authorities is another major task there. So we have to make sure that we do not do over permissioned API scopes to expose more PHI than needed. Then if we don't have an audit trail, then breaches go undetected as well. Then if you do misconfigured or top tokens, it can be intercepted or replayed. Then we have data format and standards mismatch. So obviously when you have two different systems, you want to talk to each other. Both of them have different data formats or standards. One is using HL7 version 2 messaging, then it will not be able to talk to your APIs. Then if you have a FHIR server and then the other system has a different version, that doesn't match as well. So as I was saying, systems speak different healthcare dialects or completely different languages. So you have to make sure that the bridge that you're building speaks to both of those data formats. Then we have, sometimes if they have two different data systems, we have to do a full code remapping and terminology mapping as well. Then we have to also make sure that structural transformation between both the formats is being done in a proper way. Then we have system downtime and API reliability. So, you have to also make sure that with all the heavy load that you're putting the systems through for interoperability, to make sure that the APIs that you're developing or the endpoints that you're working on are reliable. If you have a weak endpoint, the system can go down anytime, and you have to then do the whole testing and make sure that everything is up and running again. Then we have version compatibility issues. This is sort of related to the second point, which is data formats and standards. So all FHIR client apps break when the endpoint URLs change, as you might be aware of. Then the claims can get rejected silently whenever there is a pair schema update. So we have to make sure that all of these integrations are up to date and running in a way that ensures 100% compliance as well as uptime. Then moving forward, then we have some regulatory and compliance changes, as we mentioned. So HIPAA updates their policies every 3, 4, 6 months. So we have to make sure that everything is being, followed. Otherwise, there are fines during audit. So we have to avoid that risk as well. Then we have lack of internal technical expertise. So usually, small to mid clinics have 0 to 1 IT staff. So that, when we do the OpenEMR integration or when we do a custom EHR development, it's hard to teach them the new technologies or make sure that they follow our instructions to make sure all of those integrations are properly in place. Then we have data duplication and synchronization errors. So whenever there are multiple systems that hold the same copies of patient record without reliable synchronization, data integrity usually takes a hit. So to maintain that the PHI is consistent, we have to make sure that the duplication guardrails that we put in are 100% working properly. Now that we have seen the challenges, let's look at what are the possible solutions to solve these integration gaps. So the number one solution is to build on a FHIR server as your foundation, because it allows you to map all of your new integrations to all the FHIR R4 resources. And we have to use the US core IG profiles as ONC required baseline to make sure that we are following all the ONC related certification related guidelines and making sure everything is being done properly. Then we have implementing FHIR bulk data for analytics workloads. Then we have using FHIR questionnaire or questionnaire response for a structured intake. So ideally, when you are connecting multiple systems, it's advisable to use FHIR R4 as your foundation rather than working with a little bit of obsolete technology. Then the solution number two is using an integration engine or middleware. So when you use a middleware, it's easy to parse the data in the format that the system is expecting. So you have to make sure that the middleware is expecting messages in any format. Then it transforms the data and routes it to the particular system in the format that that particular system is expecting. Then we have, it also gives you a visual audit of every message. So a middleware, you can essentially build a dashboard for that particular middleware to see what are the data hits and everything. Then another security related solution is to implement OAuth 2.0 and Smart on FHIR. So OAuth 2.0, it allows, it controls essentially which apps can access the data. And then Smart on FHIR, it defines how clinical apps launch within the EHR. Then you can also use OpenID Connect. It verifies who the user is across different systems. Then every API endpoint touching PHI must use this framework. Then the solution number 4 is designed for resilience with retry and fallback. So it should have exponential backoff retry for API rate limits and outages. Then it should have dead letter queue. Failed messages should be held for review so that every failed message or failed API access should go to the DevOps team or the respective team for audit. Then we have circuit breaker, so that, if you have a circuit breaker, the entire system doesn't go down, only that particular issue goes down. Then we have, idempotent operations that prevent duplicates or retry. So that's something that's essential as well. Then moving forward, some other solutions here are as well, which is establishing a master patient index. So what it does is it essentially creates a unique enterprise master index or EMPI for every patient. So it makes sure that when the data flows, it uses that particular index across different systems. As I was saying, links all system-specific patient IDs together under one record. Any update in any system propagates correctly via the EMPI. So for example, if the patient data is getting updated in the patient portal, that particular MPI is being used to update the data in the EHR as well. And it also eliminates split charts and duplicate patient records. Then we have version your APIs and test and staging first. So obviously this is something that a lot of IT companies already use, or a lot of healthcare ecosystems already use. So we have to make sure that we are testing our APIs in a staging environment first, moving into the production environment later on. Then we have monitor, alert, and maintain. So we have to make sure that if the API error rate is greater than 1%, there is a warning. And if it goes beyond 5%, then there is a critical alert. Then lab results, if they are, staying 2 hours or more than queue, the depth, if it's more than 100, it should be investigated. So you need to make sure that you're setting up alerts for all major operations across your clinics. Then we have partnered with an OpenEMR integration expert. So if you're planning to use a OpenEMR based solution, you can partner with experts like ourselves. So we can make sure that every, HIPAA compliance, competency, and all of the solutions which we walk through right now. Then we have a simple use case walkthrough here. So let's look at across different systems how interoperability helps to make sure everything is talking to each other. So let's say for scheduling, we have a patient portal integrated with the EHR, and then the patient books an appointment via the portal at 9 p.m. Then once that is done, insurance eligibility and is auto checked as soon as the patient books the appointment. So they get the notification whether they are in network with that provider or they are out of network, or if they are ineligible for that, so they can carry cash for the appointment. Then we have a pre-visit intake form. As soon as the provider availability is confirmed, the pre-visit intake form gets sent to the patient. Then a automated SMS reminder sent 48 hours and 2 hours before the appointment. Now, on the day of the visit, the intake responses are pre-populated in the chart. Then lab orders are sent via HL7 V2 ORM and within 30 seconds of the appointment completion. Then e-prescription is sent to the pharmacy via Sure Scripts. Then unified view of visits and labs and meds are added into the EHR system. So all of these systems are talking to each other. There is no need for manual entry. Now, after post-visit, a visit summary is posted within the patient portal within 1 hour. So patient, when they reach to home, they can see their patient records and everything. And AI CDS hook flags high risk, high 30-day readmission risk. So once this flag is added, the front desk knows that, okay, within 30 days, we have to check the patient levels and readmit them if required. Then lab results are auto posted 4 hours after the HL7 ORU push. Then we see that the patient has a higher glucose here. The automated care gap alert is generated as well. Now moving on to billing and claim system. Once the provider enters the particular CPTs and diagnosis, it's auto-generated after the encounter codes. Then we have real-time scrubbing using an AI scribe, or if you have a quality control system, it checks that and scribes the appointments. Then once the payment is received, the ERAs are auto-pasted. They're posted, there's zero manual posting afterwards. Then full claims cycle is done in minutes and not in days. Then we have population health. The patient joins uncontrolled diabetes cohort on dashboard. Then a 30-day follow-up call is scheduled via care management. Then we have FHIR measure report submitted to MIPS at the year end. So patient counts towards glucose quality measure afterwards. So this is an overview of a patient visit. So as you can see, almost all the systems are talking to each other, and there is no manual calling or manual follow-up required so far. Then let's look at the impact. So, as I was saying, for insurance eligibility, rather than calling the payer, waiting for 15 minutes on their whole line, if we do a real-time eligibility check, it gives the results in 3 seconds. Then for lab order transmission, when you send it via fax, there is 630 to 60 minute. Then there is a manual re-entry into the system. If we do it automatically using the interoperability, it takes less than 30 seconds. Then for lab result posting, the lab gets back to the front desk, or they send the results via email, or any other older channels. It has to wait for a manual person to then post it into the EHR system. If we do it using interoperability, it gets auto posted and it's structured. Then for claim submission, it waits for a batch, or there's a manual QA. Then after integration, it gets same day submitted, automatically scrubbed as well. Then for patient communication, you have to call them, leave a message. For after interoperability, it's automated using multi-channels as well. For quality reporting, you have to do a manual chart audit, weeks of work. After integration, at the end of the year, it automatically generates the report and submits it for you. I think that's about it. Maybe for the next webinar, I can show you some live systems walkthrough as well. But for now, I think we are up for the 30 minutes. If you guys have any question and answers, I'll be available for another 5-10 minutes and I can answer your queries.